Hi, and good afternoon. It's Dr. Duke with Pediatric Psychopharmacology lecture for this week. All right, to get us started, I'm going to start with some general principles of prescribing practice for child and adolescents, and then we'll get into more of some ethical differences when it comes to prescribing for children, and then on to our diagnoses and our treatment. So some general principles to start us off. The clinical implementation of child and adolescent psychopharmacology differs considerably from the clinical practice of adults. Initial steps that clinicians can take in completing this evaluation generally include performing a complete psychiatric assessment of the patient and family and arriving at the psychiatric diagnoses, crafting a biopsychosocial case formulation, and developing a comprehensive and evidence-based treatment plan. In other words, with children, there are many different causes that can go into play besides just what we think straight on. With children, instead of the go-to of initially just going straight toward medication, and even with adults, we're also ruling out, but with children, they display their symptoms differently. Children often will display, and so forth, going back up to the depressive disorders, they'll display depression through anger or behavior outburst. There may be more going on, even potential abuse, as to a reason why their behavior has changed. So just make sure that you're getting a complete assessment, making sure that you're asking those things at home, genetic components, if there also runs in the family, are there poor parenting skills, is there different attachment issues at home, who is taking care of the child, are they lonely, is there possibly even where there's some neglect in the home, being able to rule those things out to differentiate what is going on with the child. And as far as school as well, when I always say comprehensive, also make sure that you're asking about school. The child may have, and we're about to cover, an ADHD diagnosis, but also rule out, is there more anxiety, distraction, things like that from bullying? What else may be going on? All right. So, more general principles. As I said, a completion of a thorough assessment is the first step for successful psychiatric treatment of the child and adolescent. Make sure that you're identifying those symptoms and indicating one or more psychiatric disorders. Also decide which elements of the disorders may be addressed with pharmacological treatments and which ones may respond to psychosocial treatments such as therapy and or environmental interventions. Maybe they actually need a change of home. Maybe there needs to be teaching. Is there external environmental factors such as where they're living that may be posing them to a threat and causing their symptoms? And also, which elements require a combination approach. And as you've learned already, that the best way of treatment, the most recommended, is both combination of medications and therapy. For adults, same as children. Another goal of psychiatric assessment is also to uncover relevant patient and family history information, which we had mentioned a minute ago, and which modalities of psychiatric treatment or which psychotropic medications may be suitable for that patient. So again, uncovering that history, if there's a history of bipolar disorder, if there's a history of ADHD, it does not necessarily mean that child has that, but be able to rule out also what were previous responses to medications from family members and so forth, just so that we're more on a watch and making sure that we prevent those same similar possible things with children as well. Assessment interview, make sure during your assessment, just as you do with an adult, you would with a child, mental status examinations, their physical exam, making sure they're seeing a pediatrician, they're getting their yearly checkups, etc. Any laboratory tests. Now that's not something we're coming after children often and trying to, because that will not be a great relationship for you guys if every appointment is associated with a blood draw. But making sure that if there is a history of any medical issues, that they're following up with their CBC, CMP, TSH, a lead level. Maybe there's lead exposure if they're in a home that is a certain age, certain paint, a urinalysis, urine tox screens, pregnancy tests, lipids, glucose, and those things, especially if you're going to use an atypical antipsychotic, then we would use more of those things to rule out those potential for metabolic syndrome. So more general principles. It is important to note that clinical guidelines do not recommend psychiatric pharmacotherapy solely to address specific target symptoms. So, and this is with children. So again, they're not just recommending meds, and this is not always the first go-to, okay? So in order to reach an agreement, though, if you do decide that maybe they do need medications, there are certain types of styles because you're not just getting the assent, which I'll have more on the next, from just the parent, but also the child. So there's an authoritative style which is presenting the options and asking the family to be able to choose, recommended in most settings. Authoritarian, being more direct with the family regarding which option and kind of actually giving them your opinion on which ones they should choose. Okay. Now this is used, the authoritarian type style is used more if a family is having difficulty making treatment choices, or maybe it's just that they've had other treatments in the past that have been ineffective, or maybe they're afraid of medications and being harmful. You'll be able to give your expertise in kind of providing which way and which route to go for prescribing for the patient and family. So, all right, I'm going to start out with some diagnoses now. So for this lecture, obviously I'm not going to go back over depression, mood disorder, etc. I'm going to focus on a couple disorders that we just haven't stumbled upon or came upon yet when it relates to pediatrics. Okay, attention deficit hyperactivity disorder, or ADHD. By the DSM-5 criteria, there are two types. Okay, there's inattentive and hyperactive, and actually there's a third type. There is a combined. Okay, 3 different types. All right, to meet for inattention. All right, 6 or more of the symptoms for children up to the age of 16, and 5 or more for adolescents 17 and older, and for adults. Okay, they had to have had the symptoms of inattention for at least 6 months. All right, and inappropriate for their developmental level. All right, again, because a child, if you're interviewing at 2 or 3 years old, they may meet for a lot of these things, and that's also why you see most children are actually not diagnosed with ADHD till closer to kindergarten or beginning school age, around 5 or 6 years of age. There are some pre-K children that are diagnosed, but not always necessarily treated. Sometimes they'll try cognitive behavioral therapy until they get to school age and have a better evaluation due to the age of the child and maturation. Okay, but 6 or more of the following symptoms: often fails to give close attention to detail, careless mistakes, school, work, other activities, has trouble holding attention to task, play, often does not seem to listen when spoken to directly, often does not follow through instructions, fails to finish schoolwork, chores, duties in workplace, kind of loses focus, sidetracked easily, starts one thing, is not before finishing another, often has trouble organizing tasks and activities, avoids or dislikes, are often reluctant to do tasks that require mental effort over a long period of time, such as schoolwork or homework. And this is where I'll have parents actually say, well, my gosh, he can focus on that video game for 6 hours at a time, but when it comes to homework, it's like pulling hair. We can't get him to do it. And that is something that is, when there is an interest, when there is a like, then children are able, even adults, are able to pull their attention more into something they like because it drives them. If it's something they're not, like sitting in class, and if it's history or English, science, whatever subject they don't find as interesting, then they're more likely to lose their attention. Often loses things necessary for tasks and activities, such as school materials, pencils, books, tools, wallets, keys, paperwork, eyeglasses, telephones, constantly misplacing things, in other words, often easily distracted and forgetful in the daily activities. Now, to meet for a hyperactivity type, okay, or if we're looking to rule out combined, often fidgets or taps hands or feet, squirms in seat, often leaves seat in situations where remaining seating is expected, often runs about or climbs in situations where not appropriate, okay, maybe adolescents or adults describe this more as feeling restless and always got to be doing something, often unable to play or take part in leisure activities, often on the go, acting as if driven by a motor, talks excessively, often blurts out an answer before a question has been completed, often has trouble waiting his or her turn, and then often interrupts or intrudes on others, in other words, i.e. butts into conversations or different games. And this is, and you'll also see this where people maybe said something before you really thought about it as well, more of the impulsivity, and it just kind of slipped out. I didn't slow down and think about things before I said. So, now in addition to the inattentive type or hyperactivity type, or if you're looking at combined, okay, there has to be also the following. Several inattentive and hyperactive impulsive symptoms were present before the age of 12, okay? Now this has changed. This used to be around 7. The DSM-5 changed from DSM-4 to 5 and extended the age to 12. But actually, there was one positive thing, and that it encompassed more. At the same time, this is a negative, double-edged sword, because unfortunately it did encompass more kids. So there were more diagnoses of ADHD now being given. Now, whether or not there is, that's the question. Several symptoms are present in 2 or more of the settings, and this is something to make sure, remember when you're diagnosing, don't just go by home. Please ask, how is home and school? If this is all home and school is great, no behavior marks, you send a scale, which we'll discuss in just a second, and completely negative, teachers not having problems, grades are great, not pulling marks, is there some parenting going on? Is there some change of home? Is there sibling rivalry? What is going on for the behaviors or the complaints? If it's just in one setting, vice versa. If it's just at school and they're fine at home, is there more going on at school than we're aware of? There has to be clear evidence that symptoms interfere with or reduce quality of social, school, and work functioning. And of course, they do not happen during the course of schizophrenia, another psychotic disorder, another mental disorder, i.e., whether make sure that you're ruling out, is this truly more anxiety? Is the anxiety and the worry causing the distraction, the inability to focus, and restlessness, or is this true ADHD? ADHD can show symptoms, especially with adults, with some anxiety and worry, but you've got to kind of rule out which one comes first. And if you treat one, we see which one fixes the other. Okay. All right, so here's what I was saying. You can have a combined, which is a little of both, okay? 6 or more criteria of either of both, okay? Both inattentive and hyperactivity. And again, at least for 6 months. Now, I did include this in asterisks because symptoms can change over time. The presentation may change over time as well. That being said, majority of children, okay, a majority of children will outgrow, all right, the hyperactivity symptoms. There's actually statistics saying that about 80% of ADHD children will actually outgrow their hyperactivity, but thus remain with the inattentiveness, and that's usually what continues into adulthood. Okay, so there might be that 20% of adulthood that you're like, oh my goodness, they're clearly ADHD. They've not quite outgrown the hyperactivity or inattentiveness. But again, when I say that, 80% of children and adolescents outgrow the hyperactivity. It does not say, that statistic does not say that ADHD is outgrown. There was a common misunderstanding for years that once you matured and got into puberty that you outgrew ADHD. It was something that you just grow out of as you get older, and that is untrue. Okay, you can continue to have issues with inattentiveness and focus being the major things, and they may see this through high school or when they get to college. Sometimes maybe they found something as a child, they got hit puberty, they got medications, they decide to go to college or further degree, and they realize, wait a minute, I don't think I've ever outgrown this. I'm still struggling and having to take more and more time to read and to study because of due to this disorder. All right, etiology behind ADHD, there's many biological factors. There are the beliefs of the polygenic neurological deficits, that there's some kind of deficit there. There's the theory of abnormalities of subcortical pathways, including the frontal cortex and basal ganglia. Abnormalities of the reticular activating system, and then structural abnormalities as far as producing the neurotransmitter abnormalities, dopamine dysfunction, norepinephrine. So a lot of times ADHD is also associated with having not enough dopamine and not enough norepinephrine, okay? Not enough. So I want you to make sure you remember that, because a lot of these drugs that we're about to cover are going to be trying to prevent dopamine from escaping, okay, from reuptaking, and also actually telling your body to produce more dopamine, okay? So now, that being on the flip side of things, think about that, okay? If we're not enough dopamine, when we cannot focus, but we've learned before when we covered psychosis that too much causes voices, hallucinations, paranoia, etc. Same possible thing can happen. You've got to kind of find that sweet spot, that happy medium with what that you need, but not overstimulated as well. All right, some diagnostic tools that we use for ADHD. For child and adolescents, we use the Child Behavior Checklist. Connor's rating scales, you can get most of these all free on Google if you want to see them. I use most often, oh no, it got cut off, but it's Vanderbilt ADHD rating scale, and that seems to be the most quick and easy. There is one both for teacher and parent, 2-page, simple. It actually outrules whether this behavioral, anxiety-based, inattentive, or hyperactive. That is one of most commonly I use. For adults, there's the Adult ADHD Clinical Diagnostic Scale, Adult ASRS Symptom Checklist, the Brown Attention Deficit Disorder Symptom Assessment Scale, or in other words, known as BADS. Okay. All right. So another thing that I wanted to just make sure that we mention, just because we're going over these medications and these drugs, and oftentimes we're really ruling out, is this been ADHD all along, or has there been more to this diagnosis besides ADHD? Okay. So autism spectrum disorder, again, DSM-5 made some changes. We did have autism, pervasive developmental disorder, we had Asperger's, and they kind of all grouped them under a spectrum. Necessarily, can we still, say this is more Asperger's? Absolutely. But they have grouped them more under a spectrum, and then what we do now is divide by the severity of it instead of calling it different diagnoses. So to be diagnosed with autism spectrum, there has to be persistent deficits in social communication and social interaction across multiple contexts, okay, or contexts. Now, these include deficits in social emotional reciprocity, ranging, for example, from abnormal social approach, failure to back and forth conversation, reduced sharing interest, emotions, or affect. Also, deficits in nonverbal communicative behaviors, such as maybe poorly integrated verbal nonverbal communication, abnormalities in eye contact, body language, understanding or use of gestures of others, or maybe even just a total lack of facial expressions and nonverbal communication. Also, deficits in developing, maintaining, and understanding relationships. Difficulties maybe adjusting behavior to suit various social contexts, difficulties sharing imaginative play, making friends, or in the absence of interest in peers. So a lot of times when you were looking at this and we're ruling out, and if you've ever had a child or been exposed, you're on about 15 months. Pediatricians, 15 to 18 month mark, actually begin to start sending, or in the waiting room before you go back for immunizations, vaccines, they get you to fill out a form, and what they're doing is asking you, does your child make contact? Is there attachment? Do they play with others? Are they affected by noises and sounds and scared easily? All of these things, what they're doing is trying to rule out. That is typically the age at the time that we begin to be able to differentiate and actually see autism more clearly. 0 to 12 months of infancy, up to 15 months, we don't necessarily know as easily if something is going on with our child, because usually at that time, again, it's feeding, sleeping, diaper changing. When speech starts coming into play, when play starts coming in, especially our walking has been delayed, all of those things, they're not walking by the time they're 15 months old. Maybe they're still not smiling, they're not playing with others, not maybe seem interested, lack of emotional attachment. These all can be symptoms and signs that portray that. There's and unfortunately there is a huge thing, of course, with the media and in science, and as healthcare providers, we try to make sure we're educating parents, but a lot of refusal of vaccines, and actually that publication was pulled due to fraud and lack of evidence to support that vaccines, specifically the MMR injection at 12 months, and depending what states you live in, 9 to 12 months actually causes autism. There is no supporting evidence. There's been more and more evidence come out that does not cause autism. Unfortunately, due to California, Hollywood, individuals and social media, etc., it has really taken off, and fortunately now we're seeing more and more of vaccine preventable illnesses coming back. But the main thing I want you to know is there is not usually any association with autism and vaccines. Okay. Now, as I was saying, the diagnoses. Okay, I told you some of the behaviors they have to have, obviously that social isolation, there's been some kind of delay developmentally, there's been something there. Now we can look at the severity. Are we verbal? You may say, people say verbal or non-verbal. Are there repetitive patterns of their behavior? Okay. Are they restricted in their interest activities? Okay. Looking at maybe they just do not like change. They have to have a set schedule. Change completely throws things out of order. Maybe there are stereotype repetitive motor movements. Sometimes it's flipping their hands, getting excited, lining up certain toys, maybe being obsessed with certain themes, trains, cars, football, That may be a certain theme, maybe it's history, and being very obsessed in that theme. This one I kind of skipped ahead, but inadherence or inflexible adherence to routines, that is again, not wanting change, not wanting very, very rigid. Maybe it's even in the food patterns as well, not changing, schedule stays the same. Maybe there's also maybe a strong attachment or preoccupation with unusual objects as well. This kind of goes back to that theme, okay? Hyper or hypo-reactivity to sensory, okay? Maybe it's loud noise or really overwhelming, or not even pays attention and responds to sense of touch, visual, light, sounds, etc. So again, severity based on social communication impairments, okay? They must be present in early development, okay? Can cause clinically, obviously, significant impairment in their social, occupational, and important areas of life. And it's also not just better explained if there is actually an intellectual disability here. Is there a mental retardation here? Is there something else going on medically that may be causing these issues? Other diagnoses, maybe there is a severe form of cerebral palsy or brain damage, fetal alcohol, to be able to rule out, is this autism spectrum? So etiology behind autism, genetic factors, there's 15% associated with a genetic mutation, okay? 50% actually increased rates if your sibling has it. It is actually often diagnosed 4 times more in boys than it is girls. There are biomarker, availabilities. Maybe there's something with an altered neuronal information processing. There's structural and functional abnormalities of the brain. Maybe environmental factors, toxins, pesticides, exposure to drugs throughout pregnancy, when mother was carrying baby, immunological factors, actual mother, her immunological incompatibilities and actually her antibodies fighting the fetus development. Prenatal and perinatal factors, were there care, were there enough vitamins in the pregnancy, avoiding of certain diets and substances throughout pregnancy. Comorbid neurological disorders, 4 to 32% have grand mal seizures at some point in time. And that is just amazing to me, that there could be underlying seizure disorder. And I've had a client who actually began to have seizures about 12 or 13 years of age, and always had the complaints of not being able to go to sleep, just absolutely too stimulated and could not sleep at night. Multiple different sleep medications, and one of the last ones was hydroxyzine, which was nothing wrong, but in that case had a seizure. They specifically thought it was hydroxyzine initially, but in reality what that did is just lower the seizure threshold along with the other medications he was already on, including a stimulant antipsychotic, that therefore revealed the seizures, but had actually have an underlying seizure disorder already. Also, psychosocial theories. Was there a good attachment? Has there been neglect, abuse from families over time? Has something actually changed the development of the way the brain works? So some clinical tidbits when it comes to autism. The goal of autism spectrum, or ASD, are to target core behaviors, improve their social interactions, communication, broaden strategies to integrate into schools, develop meaningful relationships, and increase long-term skills in independent living. In other words, there's not an actual treatment, not going to fix or reverse a diagnosis of autism, right? Just try to make it as best as possible and improve the highest quality of life possible for that patient. Maybe it is treatment approaches such as we have to get them to therapy, okay? Work on cognitive behavioral therapy, different types of working with them on their thinking, their emotions, occupational, physical, and even speech therapy if there are some developmental delays. Dietary approaches, there's beliefs about removing certain foods such as red food dyes. Maybe people will go on to the gluten-free, and even aiding in, maybe there's a lack of vitamins and minerals that we can supplement. Maybe if it's vitamin D, fish oils, different beliefs, and depending on what the symptoms exemplify. Medications if necessary, and complementary and alternative medicine, such as removing heavy metals like from lead, like the body, or even maybe different pressure points in acupuncture and things like that may be believed to be beneficial or assist in autism spectrum. So pediatric psychopharmacology, now we're actually going to get into talking about actually prescribing to child and adolescents. So a large percentage of psychotropic medications have not been adequately studied in youth. In fact, many of these compounds do not have FDA approval or indications for pediatric patients, okay? So that means what we're doing is using things, very often using things off-label. And the FDA does not regulate provider prescribing practices, so therefore it doesn't prohibit, they're not inhibiting us from using off-label, but that's why you're going to see very seldomly and very few actual FDA-approved medications for pediatrics when it comes to psychiatry. So FDA-approved indications generally result of methodology, though. There has been evidence, and clinicians should first consider FDA-approved medications when available and feasible. So they say, we want you to start out with what's FDA-approved, kind of go through your list. If it's one of those that you're trying to do anything and everything to get this child better, improve symptoms, we've had multiple failures, you may have to pull in some off-label knowledge of medications to help your patient. Now, ethical issues when you're working with these, since child and adolescents are particularly vulnerable, these are some different ethical principles to guide your practice, okay? You need to obtain informed consent and assent prior to prescribing psychotropic medications. Continue the discussion with patients and family. Let them know about the treatment over time. Maybe it's something just for a short period of time. Is it something they're going to have to be on for a long time? Was there just maybe an incident that happened and we had a removal of the family? There was potential abuse. We're now in a good family. Things are better. Could we possibly remove the medications? Informed consent and assent. Now, and I'm going to say something too here. When you're working with adolescents, okay, and their certain age, state to state may vary. In Alabama, they have a medical age of consent of 14. I believe it's the same for Tennessee. That actually consent for medications and treatment without a parent, okay? And psychiatry kind of falls too under those more protected ethical values where, it's when you're treating a minor, if they're emancipated, it doesn't count. If they're pregnant, if it's suicidal, if it's contraception, etc., these things start changing what we can and can't do and who we cannot treat. But just kind of heads up on that when you're obtaining consent. Now, the parent may with them and they're going to want consent. It's still feasible, especially if their parents are very involved in their care, to make sure you're also educating the parent as well about the benefits and risk of treatment. But ultimately, that child does make the decision. Where this becomes sticky is you're going to have maybe adolescents who don't want to take their medication, and parents are going to ask you, well, can you not just make them take the medication? Is there not just a shot? Is there something else I can do? They're just not going to take it. And the reality is we cannot make a 17-year-old female take their medication, just like we cannot make a 17-year-old female clean their room. Okay? This is not something we can just make happen, and they do have the right to be able to deny wanting to take their medications, okay? We can absolutely try to educate, we can try to convince, send them to therapy, work with them, hoping that they'll take it, but we cannot make them, okay? Unless, all right, they're in a hospital inpatient setting and their safety is at risk, safety to harm themselves or others, a little bit different situation. If you're in an outpatient, one of those things we can't just make, okay? All right, some more ethical issues continue. As I mentioned, you need the informed consent, making sure they have adequate knowledge, understanding the nature of their disorder, potential risks, benefits, and side effects of the medication. Okay, what's the expected prognosis? Hopefully, the earlier we can catch this, maybe the better prognoses. Okay, it just depends. Due to non-compliance that's very high in this field of medication or this field, makes it more difficult. And then I already had mentioned about the age-appropriate awareness and knowing what those, look into your age for your state for medical consent. So here's a chart that I made out of stimulant drugs. It's a mix of both stalls and Sodict information to put together for you. So there's the amphetamines or Adderalls, Avicchio, and the new Adenesis, which is the supposed new 16-hour release long-acting amphetamine medication. Or Modafinil or Nuvigil, used for ADHD, and often you're going to see also stimulants can be used for narcolepsy, more commonly the Nuvigil, and at the very bottom the Modafinil, the Provigil. And in fact, it was interesting, a lot of providers will pull sometimes Provigil out for ADHD, but it failed its clinical trial and actually failed due to developing Stevens-Johnson syndrome, and so they did not give FDA approval for Provigil to be used for ADHD. But you'll still see it sometimes for ADHD. But you're more commonly going to still see it with narcolepsy and in those higher doses when it comes to narcolepsy. Dexmethylphenidate or Focalin, and that is a very, very popular one. There is an extended release and short-acting versions of that. There is a 30 milligram out now. Your Sodict, I think, capped at 20. Dextroamphetamines or Dexedrine, Dexedrine Spanchules, you may see it as. Again, there's the max and minimum. Lisdexamphetamine, the Vyvanse, remember that's a prodrug, okay? And it is also marketed to last about 12 hours, up to 70 milligrams a day. Methylphenidate or Ritalin/Concerta. Ritalin, that's the short-acting, there's a Ritalin LA, okay, which is the long-acting, and Concerta, and those are used also to try to market closer to that 8-12 hour range. Methylphenidate HCl or Equivalent XR, there's also the Equivalent Chews, and they're actually kind of a new chewable tablet of the Vyvanse. They're trying to come out with more, I believe the Avicchio, to have more options for children to be able to take medications who can't swallow pills. And some of these long-actings, you can actually, for example, the Focalin, you can actually open the capsule and mix with applesauce, pudding, yogurt, etc. Where some of these medications you may not be able to actually open the capsule or crush. This gives another option for us to have those medications. They had a Daytrana patch, and I believe there was so many issues with the irritation. I've understood that they've actually don't make it any longer. It's stood into your Stephen Stahl's text. But Daytrana was another option of a stimulant patch for those who could not tolerate or take pills. So something about stimulant drugs, some topics about it. So they increase mood, energy, wakefulness, right? And that's why we use them for narcolepsy, but also we're using them for ADHD, right? We're trying to make sure that they can focus and pay attention. They're often also called sympathomimetics, also because they increase the physiological effects of the neurotransmitter epinephrine as well, again, i.e. stimulation, okay? And that's actually, when we look at adverse effects in just a moment, you'll see there's that risk of increased heart rate, blood pressure, etc. due to the epinephrine increase, okay? Most commonly used to treat ADHD, classified as controlled due to rapid onset, immediate behavioral effects, and the propensity to develop tolerance. So, tolerance meaning, we have more likely for abuse. And so that is why right now they are Scheduled II medication drugs, and they have to be more followed. They have to have that, of course, written actual prescription. Now they're actually starting to allow e-prescribing, but again, it's one of those you're just not able to put refills. If you're doing these medications and they have a stable person for 3-month checkups, you may be able to write a script and then have to write 2 additional ones saying don't fill until this date, don't fill until this date. Also, I already mentioned used in narcolepsy, and we also use them with cognitive disorders that result to secondary depression or profound apathy, with such as multiple sclerosis, post-stroke depression, dementia, and augmentation of antidepressants in the treatment-resistant depression. So pharmacological action, so that you can understand this, and this is something even through school I wanted to make sure I understand, okay, what is the difference in methylphenidates and amphetamines? So I think amphetamines are always thought, they're stronger, but why? How? Well, the primary pharmacologic effect of both amphetamine and methylphenidate is to increase that central dopamine, okay, and norepinephrine activity, which then impacts the executive and attentional function. All right, makes sense, stimulating, okay, going to focus better. So methylphenidates actually inhibit the reuptake of dopamine and norepinephrine. All right, let me stop there. Inhibit their reuptake, okay? So almost think of them as dopamine reuptake inhibitors, okay? If you want to say dopamine norepinephrine reuptake inhibitor, almost in a way, not to be confused with Wellbutrin, but they're very similar, which we'll talk about again here in a moment as well. But they are actually trying to keep your body from releasing or excreting too much dopamine too quickly, therefore holding on to it longer, therefore also increasing the levels in the bloodstream, okay? Now, amphetamines actually tell your body to increase dopamine release. So this is saying, wait a minute, let's turn on these receptors and not just hold on to it, but we're going to actually produce more dopamine, okay? So that's why they're stronger. Your body is actually physically producing more dopamine. It's being told, I need to release more, I need to release more, instead of just holding on to what you already have. So more pharmacological actions of them will absorb in the GI tract, and the amphetamine, or parentheses, Adderall and dextroamphetamine, dexedrines, reach a peak plasma concentration within 2 to 3 hours and have a half-life of about 6 hours, usually given in once or twice daily dosings. Methylphenidates, or otherwise known as Ritalin, peak in 1 to 2 hours and have a short half-life of 2 to 3 hours. Okay? Extended release methylphenidates, Concerta, Equivalent XR, peak in about 4 to 5 hours and are designed to last about 12. Dextromethylphenidate Focalin peaks in 3 and is usually prescribed BID. That is if it's the plain. Okay, there is the XR version. Kind of go back up to the rule of thumb, back up there where it says extended release methylphenidate. Dextromethylphenidate also very similar and meant to try to get those longer reacting. Honestly, with anything, guys, short acting, I tell patients you're looking at a 4 to 6 hour of relief, sometimes shorter. Most individuals, unless they have a higher metabolism, 4 to 6 hours. And if you're going to a long acting, it's because usually we're trying to get the entire school day without having to take a school dose medication in the middle of the day. So we're trying to gear towards closer to a minimum of 6, closer to most medications 8 to 12 hours. And of course, with the new adenosys, they're marketing to try to get closer to the 16 hours for those people who work maybe long shifts, have sports, etc. with kids, and need to have the longer day to be able to focus. Now, as I mentioned, the lisdexamfetamine, or otherwise known as Vyvanse, is a prodrug. It's actually activated by lysine portion of the molecule by enzymes in the red blood cells. So therefore, it has to be taken, it has to be swallowed, it has to actually be activated in the gut, okay, for it to work. It's not going to work the same if you crush it, snort it, chew it, whatever they do, okay? Inject, it needs to be activated in the gut. It needs to hit that lysine. And actually, the way it hits in those molecules in the blood system is there's a slow and gradual release of the drug, therefore reducing abuse potential and also lasting longer in the system. Now, therapeutic indications. These are stimulants are the first-line drugs for treatment for ADHD. They work about 75% of the time. Methylphenidate and dextroamphetamine equally effective, work within about 15 to 30 minutes. Improve both inattention and hyperactivity symptoms. Methylphenidates, most commonly used, again, 5 to 10 milligrams every 3 to 4 hours, can be increased up to a max of 20 milligrams 4 times a day. Or, and I like this, and I need to find the amphetamine one, but they're very, very similar in the way that they function is that, remember that 1 mg per kg per day. Now, Stephen Stalls says up to 2 mg per kg per day. So I guess you could do that range, 1 to 2 mg per kg per day, and just kind of assess the situation and severity of the symptoms. Also knowing this as a child at Pediatric. Now, I have heard different beliefs that, oh, no, children cannot tolerate as high of a dosing. They have lower dosing. And that is true in some aspects. And I've also had psychiatrists teach me that, you're gonna increase and treat to the symptoms. So it's kind of that goes back to that whole we go up until there's a side effect or symptom relief. And there's also belief there we just got to be a little bit more slow when we do that with children, but it doesn't mean they can't have the max doses of some of these medications. Now, sustained release methylphenidates, as I said, designed to provide 6 hours of benefit and prevent dosing at school. Dextroamphetamine is about twice as potent as methylphenidate. So if you're looking at the milligram basis, and again, that can kind of compare. So, how much of, if I'm on 5 of Adderall, maybe it's, is it 2.5, is it 10 of Focalin? Maybe I'm on, Vyvanse. I'm sorry, I was going to do an amphetamine to an amphetamine. But that's very interesting actually to look at. If you'll look at your Stephen Stalls and even your SODICT book, there's actually charts in there as far as conversion. It's very, very helpful. I know in my practice as well, converting Adderall XR into Vyvanse and Focalin over to Adderall, being able to understand, what's the even comparison when you're switching medications. Doesn't mean you just can switch right over. You may not be able to start as low, and also educating your parents and your patients that they may have, this dose may not be exactly equivalent, but that you'll get them there. You want to rule out, make sure no adverse effects and tolerability before you continue to increase the medication. Adverse effects, and actually I'm not sure why specifically on the chart of your SODICT it didn't include, but I had already mentioned there is an increase in heart rate and blood pressure, possible chest pain. You do want to rule out a cardiac history. With my children, I don't necessarily say, hey, you're going to have an EKG before I start any stimulant for every adolescent or child. Not necessarily. If they do have a history where a close family member, relative dropped dead early, heart attack, an early age, no reason, really no warning indications, or there's a huge cardiac history in the family or the client, and then therefore I may send them to a cardiologist to rule out. But usually not drawing EKGs or following up unless there's been actual chest pain complaints or etc. for me to look into it a little bit more to find out what is going on, okay? And sometimes those are just dose dependent as well, or maybe it just means they can tolerate more of a methylphenidate base than they can an amphetamine based. But adverse effects should have included also increase in heart rate and blood pressure as possible. We keep an eye on those. More commonly, though, you're going to see anorexia, weight loss, and nausea. It is encouraged to administer with meals. And in fact, because of children getting up, taking their medication, they may not want to eat lunch, okay? They're not going to be as hungry. Stimulants can decrease your appetite. Therefore, they also, that's kind of like they give them for weight loss when they're prescribing stimulants for weight loss for those who are going through Adipex and those type diet plans. They're taking those medications to decrease their appetite. Well, thus and forth, these do the same thing, okay? So I try to encourage my kiddos to get up and have some kind of breakfast, something on their belly to prevent it from causing a nausea, tummy upset. But also, too, knowing that they may not eat lunch, there is a possible for weight loss, and a little weight loss may be expected initially starting a stimulant, but we want to make sure that it's not continuing to lose weight and that we're staying in healthy range as far as being able to still thrive on our growth charts and not dip down as far as when it comes to the medications. Insomnia is possible. We do administer early in the day. And this is like, well, but that sounds reverse. You are going to have some people in ADHD who can say, but I drink caffeine and I can go right to bed. Yeah, I mean, caffeine is a stimulant. And this is, again, it's a possible adverse effect. Some people, it will not phase, but it is possible because it is increasing that dopamine and trying to help you to focus. You don't necessarily need anything to specifically focus or keep your brain on when you're ready to go to bed. So we do encourage earlier in the day. If they're going to have to be on a short-acting dose after school for homework, sports, etc., then we try to encourage between 3 and 4 p.m. and no later, just so that it's not messing with their sleep. Okay. If it is, and we're doing wonderful, maybe they just might need something like the hydroxyzine/Vistaril add on for sleep, clonidine. There are other different medications we can add on to help with the insomnia. Dizziness is possible. Monitor here, go with the BP. Okay. Encouraging fluids as well. Sometimes when they're going and they're focused and they're doing great, we also have to make sure that they're stopping to get fluids and they're staying hydrated as well. One way to prevent the dizziness is changing to a long-acting so that medication actually is slowly releasing more often throughout the day and not just one big boom hitting the system, depending on what drug it is. I will stop and say that some of your, like for example, Adderall XR versions actually release half in the morning and then half about 4 hours later, whereas in your Vyvanse or Focalins are more going to release slowly throughout the day. Rebound phenomena, this is always interesting. So, sometimes it's people just, and child adolescents just have a higher metabolism or the way they react to the drugs, it leaves their system quicker and they can actually maybe be more rowdy, more hyperactivity. Definitely realize that the medication has run out. It also can rebound into irritability, which leads me into the next one. So it's very important that when they're saying that their child has been more irritable, what time of day? Is this when the medication's peaked? Are we having trouble at school? 30 minutes to an hour after we've taken the medication, they're just awful. Or is this when we're coming home in the afternoon and like, I notice they're so irritable around 4 or 5 o'clock and it lasts for a couple hours and then they're fine. They may be withdrawing from the medication. There's a couple things that we can do there. It might be feasible to add a very, very small short-acting dose to compensate for that and to be able to take it. I've had children even take it at like 2 o'clock at school just to help prevent coming home that way or when they first come home. Sometimes the larger the dose, the longer it lasts, depending on the child, the symptoms. Are there other issues throughout the day or is it just in the evening? Okay. You may actually be able to reduce dose if it is due to the peak, okay, and not necessarily the withdrawal. And of course, we do want to rule out, is there any comorbid diagnoses going on here when did this actually begin, okay? Which leads me into the dysphoria, moodiness, and agitation. We do want to consider mood disorders. If they begin to show these things, again, I said children often will show depression through agitation, moodiness, etc. And so we might need to consider adjunctive treatment. There may need to be antidepressants, there may be lithium, anticonvulsants if this is a mood disorder. Also, please rule out, though, is this because of the medication? Unfortunately, sometimes related to that increase of dopamine, there have been children who have actually been more dysphoric and who have actually been more angry or even hearing voices and hallucinating due to the overstimulation of the medication. Okay, so be very watchful of that. Make sure no suicidal ideations as well. I have in my practice recently seen an adolescent who we believe that since their dose was increased of Adderall, actually began to have hallucinations and more dysphoria. So non-stimulant drugs such as the atoxamine or Strattera, that is actually a non-stimulant. I mean, it's stimulating in the way that we think about it, but it's a non-controlled, let me say it that way, a non-controlled medication, okay? It actually and then sometimes you'll see the Strattera, if they have anxiousness and inattentiveness, you'll see Strattera used, but it is a norepinephrine reuptake inhibitor, okay? Nothing with serotonin, all right? Selective norepinephrine reuptake inhibitor, or in other words, an NRI. The first non-stimulant approved by the FDA for treatment of ADHD. Long-acting, so it only requires a once-a-daily dosing. A lot of times people take it in the morning, although there is some tummy upset possible with nausea, is a lot of things, and headache that you'll hear most commonly with Strattera. And so there are a few people who actually take it at bed, and by the time that it actually peaks, they're getting up in the morning, as long as it does not disrupt their sleep. They may have less likely to have the tummy upset and headache. So starting dose is usually 20 milligrams. Usually daily dose is around 40 to 80 daily. A max up to 80 for children, up to 100 for adults. Bupropion, or Wellbutrin, as we've discussed already in the past with antidepressants, is a norepinephrine dopamine reuptake inhibitor, or an NDRI. Okay, they can also be used. I mean, it is still hitting very, very similar to what our stimulant medications are. And a lot of times, this is my first go-to for adults. I will actually try Wellbutrin first and dose it up, and also see what the reaction is as well. See how they respond. If those patients who have bipolar disorder and also ADHD who truly have two things going at once, can you do a stimulant? Yeah, it's possible. If they've had any history of psychosis or any history of mania, I might be on more alert, and I might be able to go with the Wellbutrin, a little less likely chance of throwing into mania or psychosis, and still can be well tolerated as long with their diagnosis and helping with their inattentive symptoms. Usual dose is 150 to 300 milligrams daily. I will say with XLs, we push it up to 450 milligrams as needed. And I like the XL dosing a little bit better, especially if we're already treating someone who has difficulty with organization and remembering things. Remembering dosing your medication 2 or 3 times a day can be a little excessive and hard to remember, so the XLs usually are better options. Alpha adrenergic agonists, we actually use these are just old blood pressure medications, okay? We're really not sure 100% how they work, okay? But there is the belief that they reduce hyperactivity and the impulsivity. They can also help with some irritability that we mentioned on the previous slide. Useful as well when you have, they'll say, oh, but this causes tics, movements, blinking, grimacing, clearing the throat. Also, we use these in Tourette's disorder treatment as well, which is obviously displaying the tics. There is a belief these settle down those. Now, I want to make sure I fix a common misperception, is that stimulants cause tics. Stimulants do not actually cause a tic. Most often what it is that a child actually has been predisposed or more likely to have an underlying tic disorder, and the stimulant actually brought the tic out. It's not necessarily causing it, but it can bring it out. Now again, depending on how disruptive, it may not be bothersome, and the benefits outweigh the risk, and they do nothing. If they are pretty bothersome, people are noticing they're blinking their eyes or clearing their throat, disrupting class, we may be able to add medications such as our clonidine or guanfacine, excuse me, please do not think guanfacine to those to help decrease the tics from the medications. Okay, but now these are old blood pressure medicines, so we do need to monitor their blood pressure. They also can be sedating, so a lot of times we'll start these at bedtime and see how their reaction is before we dose them. Can we dose during the day? Absolutely. Okay. Clonidine, for example, or Clonidine XR, they've come out with a cap bay so that you don't have to dose it quite as often. Usually we start at the 0.1 milligram at bed and can increase by the 0.1 each week. The short acting can be dosed up to 3 times a day. If you're going to use Cat Bay, we can actually dose it to 0.2 milligrams twice daily and actually get away with more often the once daily at bedtime and not have to do the multiple times a day to remember medications. Guanfacine or 10X, there's actually the XR version, is called Intunif. Initially, we're starting 1 milligram at bedtime, and we can increase by 1 milligram each week. Oftentimes, you'll see the starting is usually, and depending on your case, start 1 milligram for the first week, then increase to 2. Make sure that you get them back within about 2 weeks so we can check on their blood pressure. They can drop their pressure. Let them know there are children who do tolerate them better in the morning. I've got a patient who has, I'm believing, ruling out ADHD, who's also been previously diagnosed with autism spectrum, that we do the Intuitive in the morning and is working wonderfully to decrease irritability and lasting throughout the day. Their routine just worked a little bit better in the morning than it did in the evening. Usual doses, if we're doing short acting, are 0.5 and 1.5, 2 to 3 times a day. And in Intuitive, we can just dose up to 4 milligrams per day, usually in the evening or again once a day, if the morning if possible. And there was something else I wanted to make sure that I added here as far as alpha adrenergics. Oh, if they cannot tolerate these medications and maybe they're having blood pressure issues, please be mindful to do not just stop these medications. Please taper these medications. You can actually have rebound hypertension or worsening symptoms. So if you do decide they're not able to tolerate these medications, they do need to be weaned over a few days at a time to a week at a time before stopping. All right, so this was more of a shorter lecture. There's my references for this end of our lecture. If you think of any questions or concerns, please let me know. Please reach out by email or if you need to contact my cell phone. Also, please, I encourage you as always to jump in the forums, be an active part of the community in the classroom as far as the discussions. And I hope you all have a wonderful week and I will see you soon. Thank you.